teachers and seniors and colleagues. Today we are doing our first journal club since the installation of its new office bearers also. And today we have a very interesting paper about a very important topic on Kawasaki's disease. And we are joined by none other than my beloved teacher and a great person, and none other than the HOD of Pediatric SCTIMST, Dr. Lakshmi Madam is with us. And also my a great friend and teacher and senior, faculty, Dr. Harikrishnan sir has also joined with us. And we are blessed with Dr. Purushottam sir present today. So we may be having a few teaching sessions, interesting thoughts and discussions that we will see as the session goes by. And before we go to the session proper, I would like to invite Dr. Benno, Andrew, who is the secretary of IAP Thiruvananthapuram, to say a few words.
Thank you, Dr. Anju Kanmani. On behalf of IAP Thiruvananthapuram, I would like to thank each and every one of you for joining. And over the last 1 year, our vibrant Joint Secretary, Dr. Anju Kanmani, has been hosting this and conducting this journal club very meticulously. And thank you, Dr. Anju Kanmani. And I would like to thank Lakshmi Madam, Ramankutty sir, Harikrishnan sir, and Padmanabhan sir for spending their valuable time and giving us a very valuable academic feast. And without further delay, I would request Anju Kanmani to start off with the journal presentation. Thank you.
Yeah, there is no need. Thank you, Dr. Benno, and thanks for the inspirational words. With our support and hard work, I think we will go, try to do our best. And there is no need to, tell about the expert panel. None other than Dr. Ramankutty sir is here. Sir is a professor emeritus of SCTIMST, Ashitha Center. And sir is a great teacher and is a research scholar. And sir has been always with us and so friendly and so, very in a caring way. Sir has been guiding us through all this journal club and pointing out every single interesting aspects of the articles being presented and all. Today, the PG is who is presenting is from SAT Hospital postgraduate. Is none other than Dr. Sharon Fredrick Lasrado, JR2 Pediatrics, SAT Hospital Trivandrum. And before Sharon is presenting, I think Dr. Harikrishnan sir will give a few introductory remarks as far as this article, as far as Kawasaki's disease is concerned. Over to Dr. Harikrishnan sir.
A very good evening to all. I'll just share a few thoughts and a background for this current study. So I'll just discuss a short introduction, current management strategies and guidelines for Kawasaki disease, and the different cohorts of patients used for the scoring systems over the years. A brief note on IVIG, the adverse effects of IVIG and effectiveness of low-dose IVIG and the concerns for the same. So as everybody knows, KD vasculopathy involves three processes impacting the muscular arteries. So it's a necrotizing arthritis followed by subacute or chronic vasculitis and luminal myofibroblastic proliferation. It's a medium vessel vasculitis, usually less than 5 years, higher incidence in Asia. Coronary aneurysms develop in up to 20% patients and almost 50% regress within 6 months. 20% of the aneurysms can progress on to stenosis, and sudden death has been reported due to MI pericarditis, myocarditis, that is in the acute phase, heart failure. So this is the current AHA 2017 guidelines. I'm sure everybody knows it. Presence of more than 5 days of fever, more than or equal to 4 principal clinical features. And there is a definition for incomplete KD2 in the guidelines. What is the concern? So is it not like all the other viral infections? So this is the concern, a major concern, because as you can see, this is an echocardiographic picture, a short axis view showing aorta in the center, and just to the left of aorta, we have a huge dilated structure with some hypoechogenic structure inside. So that's a dilated coronary artery, dilated LAD, a proximal LAD aneurysm with thrombus inside. So that is a cause for concern. You can see this is a reconstructed CT of a patient who had Kawasaki, showing dilated coronaries throughout. Even long-term follow-ups have demonstrated that patients can have dilatations and stenosis on long-term. So what are the current guidelines? Echocardiography should be performed and diagnosis is considered and repeated at 1 to 2 and 4 to 6 weeks after treatment. And it is classified based on the C scores. That is the most commonly accepted methodology now to derive the C scores and then classify as no involvement dilatation when it's less than or equal to 2.5 C scores, small aneurysm, medium, and a large aneurysm. Treatment sure everybody infusion and a moderate to high doses of aspirin, that is anti-grams, that is activated dose of aspirin. Single dose pulse methylprednisolone should not be administered as primary therapy, and other adjunctive measures like corticosteroids together with IVIG and aspirin may be considered for high risk patients. So this is what I was just talking, just summarizing. So first is intensification of treatment. Persistence of fever for 36 hours after the first dose of IVIG is considered IVIG resistance. The current definition, this is important because as we discussed in the paper today, there is slight deviations from all these definitions. And if it is resistant, the dose is a repeat dose of IVIG or multiple other options like methylprednisolone, infliximab, cyclosporin, etc., and then continue low dose aspirin. So IVIG resistance has been reported in around 10 to 20% of patients, and all the studies have been basically towards finding this high risk group who are likely to have IVIG resistance, because it has been proven beyond doubt that IVIG helps in preventing the development of coronary artery aneurysms. So these are all the different scoring systems available. As most of us would have heard about Kobayashi score. Harada score was the earliest score in the 90s. Kobayashi score came in 2006. Together with Kobayashi, there was Egami, Formosa. All those came in that initial 2005 to 2010. And the other scores like Hua score, Tang, and all are little more recent. As it is evident and understandable that most of these scores have originated in Japan, where the disease itself was found out. But the other population, that is, it is little higher in Asia. So all the other scores like Hua, Formosa, and Tang score, all that have originated in China, Formosa in Taiwan, and there's only one US score, the San Diego score, which is basically they've also tried to tell that it is different in a multi-ethnic population. The scores are not applicable in all the populations, but you can see that most of the scores have these parameters, that is age, liver function, platelet count, CRP, sodium in the Kobayashi score, and days of illness at initial treatment less than or equal to 4. That is earlier treatment with IVIG in Kobayashi score, Egami score, etc. And this recent scores, they found days of illness at treatment more than or equal to 7. That is late treatment also leads to coronary artery aneurysms and IVIG resistance. All these scores are basically directed at IVIG resistance and as a as a sequelae coronary artery aneurysms. So I'll not go to the cohort. I wanted to show this because you can see Kobayashi had 528 patients and Harada had 865 patients, but Harada was basically to see which patient would require IVIG, because IVIG was not available that time very frequently in the 90s. So this was basically, we cannot say that all the patients were treated with IVIG. Kobayashi, all the patients were treated with IVIG, but that to 1 gram per kg. Egami, Formosa, and all the other scores, it was by that time it was already established that 2 gram per kg is the appropriate dose. But all these criteria in terms of resistance of IVIG, there was differences in the function. So this is IVIG developed by Bruton for A gamma globulinemia. IVIG is a very good drug, but what are the adverse effects? There are multiple adverse effects, all related to the high dose. So flu-like symptoms, dermatological adverse effects, those are manageable. Arrhythmia, hypotension can be even fatal. Transfusion-related acute lung injury again can be fatal. Thrombotic events have been reported, and others like aseptic meningitis, renal impairment, and hemolysis. So this was one of the studies which showed in 48,000 patients. All these are propensity scored analysis. None of the studies are like long-term follow-up studies. So significant difference in percentage of IVIG resistance between the groups. That is high risk versus 2 gram per kg versus 1 gram per kg, but no significant difference in coronary artery aneurysms. And this was a recent publication, 88,000 patient data, which was seen. As you can see, this from 2010 to 20. So most of the patients have received almost 2 gram per kg. Their lowest dose is like 1.8 gram per kg, and the highest dose is 2.4 gram per kg. They have found a U-shaped association. That means they found that 2 gram per kg is the ideal dose. Both below that and above that is not harmful in terms of is harmful, sorry, in terms of coronary artery aneurysms. And a meta-analysis also here they have shown that there's no significant difference in coronary artery lesions, whether it's acute, subacute, or at 6 month and 1 year follow-up. But you can see that the follow-up is very, very less. So just some things to ponder. What are high risk versus low risk patients, and how to identify those patients? Are there problems of undertreatment? Because even one child getting that kind of coronary aneurysm, which I showed, is not acceptable. So are there problems with undertreatment? Are there problems with overtreatment? Are we very the day the child comes itself, are we overtreating and trying to give all the drugs so that coronary artery aneurysms does not develop? That is also another thing to ponder. And obviously, this paper is directed at that. Can we use lower dose of IVIG in low risk groups? And what kind of data would help in decision making? So I would hand over to Dr. Sharon to present the paper. Thank you.
Thank you, Harikrishnan sir, for that excellent presentation, that beautiful echocardiogram, that updation and recent. I mean, it was very an enlightening presentation and all. So, Dr. Sharon, can we start your presentation? Or to Dr. Sharon.
Good evening to everyone who have joined this Zoom session, respected mentors, respected sirs, and the esteemed audience. It is indeed an honor for me to present this paper in this journal club discussion. Without further ado, I would like to go to the presentation. The paper for presentation today, Stratified Therapy for Kawasaki Disease using a new scoring system to predict response to a lower dose of intravenous immunoglobulin therapy by Matsuura et al. At Saitama Medical Center, Jichi Medical University, Saitama, Japan. Kawasaki disease, a systemic vasculitis affecting the coronary arteries, is the most prevalent acquired heart disease in children in developing countries. 25% of untreated patients and 5% of treated patients can develop coronary artery lesions. High dose, that is 2 gram per kg IVIG and aspirin, are the standard treatment for Kawasaki disease. Resistant Kawasaki disease or IVIG non-responders could be seen in 10 to 20% of patients. Non-responders would need additional therapies, including a repeat dose of IVIG or steroids, immunosuppressive drugs, or infliximab. Fever for more than 5 days with the following components, 4 out of which is considered as classic Kawasaki disease: maculopapular rash, strawberry tongue, periangular exfoliation, extremities edema, and dilated coronaries, also working towards a supportive diagnosis. If any of these features are found to be incomplete, there is the concept of incomplete Kawasaki disease, where the diagnosis is made complete by laboratory parameters. The scores of Kobayashi, Egami, or Sono, as discussed during the introduction, have been proposed as a prediction of resistance to standard therapy. These additional therapies in patients with resistant IVIG alone. KD is not severe in all patients. Based on the observed clinical outcomes of the patients at the institution where the study was carried out, the authors have reported and proposed a new score known as less high-risk score that can be used to identify a strata of patients in whom a lower dose of 1 gram per kg IVIG will be effective. The study's materials and methods. It is a retrospective cohort study since the cohorting is not well defined, which I would mention in the I would rather write to remark were included. 64 patients were excluded for various reasons. The patients were divided into 3 groups: high risk, moderate, and low risk, based on
Excuse me, Dr. Sharon.
Yes,
I think there is some issue with the audio and that. And can you be a little louder and start from the beginning? This can you start with this materials and methods once more, please? Thank you.
okay. Am I audible?
Yeah, you're audible.
Okay. Materials and methods. The study is a retrospective cohort study since the cohorting is not well defined in the paper. As I would remark during the critical analysis, I would like to remark it as a retrospective case sheet analysis. The authors retrospectively evaluated the clinical records of 341 patients with acute Kawasaki disease treated in their center. 64 patients were excluded for various reasons. In the end, records of 277 patients were analyzed. Kawasaki disease was diagnosed according to the Revision of Diagnostic Guidelines for Kawasaki disease, 6th revised edition. The patients, 277, were divided into 3 groups, known as high-risk group, moderate risk group, and low-risk group. High-risk group had a Kobayashi score of greater than or equal to 5. Moderate risk group had a Kobayashi score less than 5, and the new less high risk score of greater than or equal to 2 points. Low risk score group had a Kobayashi score of less than 5 and less high risk score less than 2. In the subsequent slides, I would be discussing the scores. Kobayashi score is the well-established and peer-reviewed score for primary IVIG resistance. It has the following components. A sodium value of less than or equal to 133 millimoles per liter carries 2 points, with less than or equal to 4 days of initial illness at initial treatment carrying 2 points, an elevated AST level of more than or equal to 100 carrying 2 points, in the differential count percentage neutrophils carrying more than or equal to 80% carrying 2 points, a CRP level of greater than or equal to 10 carrying 1 point, age less than or equal to 12 months carrying 1 point, and platelet count less than or equal to 3 lakh carrying 1 point. Kobayashi score has been universally taken to be significant if the cutoff, the score, is greater than 4. But for reasons the authors have not explained, they have taken a cutoff of 5 or more. The authors have proposed a less high-risk score. A less high-risk score, which the authors have proposed, comprises of the following components. In the differential leukocyte count, percentage neutrophils greater than or equal to 70% carrying 2 points. A serum sodium concentration less than or equal to 133 carrying 1 point. An AST value greater than or equal to 110 carrying 1 point, and C-reactive protein greater than or equal to 10 milligram per deciliter has 1 point. The less high-risk score determines the category of significance if the total is more than or equal to 2 points. So this is how the patients were stratified. A Kobayashi score greater than or equal to 5 were out and out grouped as high-risk group. Kobayashi score less than 5 further divided into 2 arms. Less high-risk score greater than or equal to 2 in this arm was supposed to be moderate risk group, and less high-risk score less than 2 in those who have a Kobayashi score less than 5 were assigned to low-risk group. Treatment. All patients received aspirin at 30 milligram per kg per day for 48 hours or more after fever reduction, followed by a lower dose of aspirin at 5 milligram per kg per day. Patients who did not respond to the initial therapy within 24 hours after the end of IVIG treatment, or those who had recurrent fever, were considered non-responders. As we see, there is a deviation in the standard treatment guidelines. The initial treatment for those who have belonged to the low risk category involved aspirin and only 1 gram per kg IVIG. In the moderate risk group, they received 2 gram per kg as per standard treatment guidelines along with aspirin, and the high risk group received 2 gram per kg IVIG along with aspirin along with oral prednisolone. Those who were defined as non-responders, that is afebrile within 24 hours as per the author's definition, were termed as non-responders, and in those population belonging to the low risk category, they were given once again a repeat dose of only 1 gram per kg IVIG. Those who belong to the moderate risk category were given 2 gram per kg IVIG along with oral steroid. And those who belong to the high risk category were given repeat dose of 2 gram per kg IVIG along with either methyl prednisolone pulsing or IV immunosuppressants. The table has summarized what is the deviation from the management. The laboratory data, echo findings, and other medical records were compared between the groups. The patient's age, sex, and days of illness were recorded. The lab parameters, including white blood cell, neutrophil, platelet count, C-reactive protein, NT-proBNP levels, etc., were measured. The diameters of proximal right coronary artery, left main coronary artery, and proximal left anterior descending artery were determined before and after treatment and after 4 weeks as a follow-up. The acute treatment clinical course and prognosis for 4 weeks were evaluated in patients with coronary dilatation. The outcomes were defined as follows. The primary outcome, response to initial therapy, defined as the patients were afebrile within 24 hours after the end of intravenous immunoglobulin treatment who did not have a recurrent fever. Secondary outcome. The secondary outcomes were coronary artery lesions of a Z-score greater than or equal to 2.5 within 4 weeks after the start of treatment, and the Z-scores of the right and left coronary arteries 4 weeks after the treatment. While the primary outcome is well defined, the secondary outcome just means this, that the outcome was defined as significant when there was a coronary with a Z-score greater than or equal to 2.5 at the beginning, and those patients' Z-score immediately after treatment and 4 weeks after treatment. This was defined as the secondary outcome. The patient's backgrounds, laboratory data before treatments, response rate to initial therapy, and mean values of coronary artery diameters and Z-scores before and after therapy and after 4 weeks are compared between the two groups. Positive predictive value of the less high risk score was defined as the response rate of the low risk group. Positive predictive value of the Kobayashi score was defined as the response rate of the moderate risk group. Positive predictive value of both the scores were compared. Categorical variables were compared using Fisher's exact test, and one-way analysis of variance was used to compare continuous variables. Pair treatments was used to compare changes over time in continuous variables. Statistical analysis were performed using the proprietary EZR 1.33 software, which was run by the university, and statistical significance was defined at a p-value less than or equal to less than 0.05. This is the baseline characteristics of the patients presented. Here we can see a significant male preponderance in the population. Also, there was significance attached to most of the laboratory parameters at presentation. Notably, there was significance for C-reactive protein, AST value, sodium value, platelet count, and percentage neutrophil, thereby validating the application of the score. A total of 207 patients, or 74.7%, were responsive to the initial treatment, including 67% or 77% to the low risk group, 72.5% to the moderate risk group, and 74.5% to the high risk group. There was no significant difference in the treatment response between both the groups. The positive predictive value of less high risk score was 77%, and that of Kobayashi score was 72.5%. Applying tests of significance, there was no significant difference between the positive predictive value of both the scores. Thereby, the authors are trying to propose in the discussion part that the less high risk score can also be used for risk stratification. 13 patients primarily at entry, 4.7%, had coronary artery lesions, 2 in the low risk group, 3 in the moderate risk group, and 8 in the high risk group. The rate of coronary artery lesions did not significantly differ between the 3 groups. Out of the 2 in the low risk group, they both did not respond to initial treatment, but they resolved spontaneously. 3 in the moderate risk group. 1 patient responded to initial treatments. In 2 patients, it resolved spontaneously, and 1 patient was transferred to an advanced center due to a suspected intramural thrombus. 8 patients in the high risk group with a primary coronary artery lesion. 1 responded to initial therapy. 3 had responded spontaneously. 2 patients responded were transferred to an advanced medical center, and 1 was discharged. There was no significance in the Z score between the 2 groups before and after treatment. In this study, low-risk patients were treated with 1 gram per kg IVIG based on less high-risk score and Kobayashi score. They did not have a decreased response rate or increased coronary artery lesion rate compared to patients with a moderate or high risk who were treated with 2 gram per kg IVIG. These results indicate that initial treatment with 1 gram per kg of IVIG is sufficient for patients identified as low risk by less high risk score, the authors have concluded. In a studies conducted by Sakata et al., comparing the initial 2 gram per kg IVIG and the initial 1 gram per kg IVIG, additional 1 gram per kg for non-responsive cases as done in this study, there was no significant difference in the incidence of coronary artery lesions, but 58% of patients in the initial 1 gram per kg IVIG group became unresponsive and required additional treatment. Therefore, based on previous reports, it has been traditionally inferred that the treatment with 1 gram per kg IVIG is inferior to 2 gram per kg IVIG. There is one small technical snag.
Okay.
I apologize for the technical snag.
No issues. Sharon, please continue. Please continue.
Therefore, based on previous reports, it has been traditionally inferred that treatment with 1 gram per kg IVIG is inferior with treatment with 2 gram per kg IVIG. Yeah. But the authors have identified patients with the low risk of non-responsiveness and successfully treated them with 1 gram per kg IVIG. The initial therapy was successful in 77% of patients in low-risk group, and non-responders also had good long-term prognosis with additional treatment. Furthermore, the researchers promptly administered an additional 1 gram per kg IVIG to any patients who are unresponsive to the primary treatment by the 9th day of illness. Therefore, they argue that the stratified therapy did not significantly deviate from the latest Kawasaki disease guidelines. The predictive value of both the scores were not significantly different as well. Using these 2 scores, the author proposed that clinicians can divide Kawasaki disease patients almost equally into 3 groups according to the response to IVIG therapy and make stratified therapies. They focus on stratified therapies being important to reduce the cost and reduce the medical expenses for patients with high risk of non-responding while minimizing the excessive use of IVIG in patients with low risk of non-responding. Now on to the critical analysis of the paper. The paper is a retrospective cohort study. Rather, I would like to remark it as retrospective case sheet analysis because the cohorting, as we would realize, is not well defined in the study. The reason it is retrospective is that the exposure has occurred before the start of the study. If we consider it as a retrospective cohort study, it comes in the following level of the study pyramid: above case control and below randomized control trials. Because it is an observational study, I would like to apply the Strobe statement for critical analysis. This is the questionnaire of the Strobe statement. Strobe checklist, title and abstract. Let us first go back to the title. Stratified therapy for Kawasaki disease using a new scoring system to predict the response to a lower dose of intravenous immunoglobulin therapy. This was the abstract. Several steps. It describes the background, the methods, the results, and the conclusion. The conclusion is that the therapeutic response rate and the therapeutic effect of low dose intravenous immunoglobulin in the low risk group identified with our new scoring system were satisfactory. Stratified therapies for patients with Kawasaki disease system may be useful. Does the paper indicate the study's design with a commonly used term in the title or the abstract? It conveys the paper's content in a crisp manner, but leaves out mentioning the study design. Does the paper provide in the abstract an informed and balanced summary of what was done and what was found? It was a structured abstract. Does the paper explain the scientific background and rationale for the investigation being reported? The background and rationales part was brief, crisp, and it conveys the disease burden of Kawasaki disease very effectively. But it does not convey the complications, particularly due to undermanagement, as was stressed upon during the authors are pioneering in their listing of this widespread application. State specific objectives, unfortunately, no. Does the paper present key elements of the study design early in the paper? Does the paper describe the setting, locations, and relevant dates, including the periods of recruitment, exposure, follow-up, and data collection? Is eligibility criteria and given clearly with sources and methods of selection of participants? Was matching criteria given? Let us come to the study design part. This was the segment in the paper which speaks about these sections. The study design is not explained, the cohorting is not explained explicitly, as I had mentioned earlier also. The setting has been explained well. Participants have been summarized effectively in this graphic. Does the paper define all outcomes, exposures, predictors, potential confounders, and effect modifiers? I would like to go back to the outcomes. Primary outcome is defined as response to initial therapy, defined as patients who were febrile within 24 hours after the end of IVIG who did not have a recurrent fever. Secondary outcome was nothing but the Z-score before and after treatment and after 4 weeks in those who had a primary coronary artery lesion as defined as a Z-score greater than or equal to 2.5 at presentation. My greatest critique, in her humble opinion, in this paper comes in this segment. The outcome is narrow in its approach. The secondary outcome has been defined in a rather vague manner. Kawasaki disease, a medium vessel vasculitis, is a multisystemic disease entity whose full spectrum of effects we are as a medical community still coming to terms with. The vast expanse of knowledge, nevertheless, tells us that the Kawasaki disease outcomes cannot be merely limited to the mere disappearance of fever and the resolving of echogenic coronaries. Effort had to be put by the authors into looking into other potentially threatening consequences like dyselectrolytemia, protein loss, or myocardial involvement, myocarditis, each of these which have been mentioned in the study's baseline characteristic analysis like the sodium level or the NT-proBNP levels. Nevertheless, such an approach may have entailed a complex analysis and application of multiple tests about potentially less objective factors, thereby affecting the end p-value of the study perhaps. This therefore stresses the need for many more randomized control trials and meta-analysis or systematic reviews to validate this study design. Two other deviations. The American Heart Association in 2017 defined IVIG non-responder of those who have fever within the first 36 hours after receiving IVIG. The authors have, for an unexplained reason, taken the cutoff as 24 hours. Also, as I had mentioned earlier, and as was mentioned in the initial presentation, Kobayashi score cutoff of significance is 4 or more, but the authors have taken 5 or more for reasons which have not been explained. Does the paper for each variable of interest give sources of data and details of methods? Yes, the sources of data have been given. Have any efforts put to address potential sources of bias? Unfortunately, no effort has been put to address potential sources of bias. This is how the baseline characteristics of the patients were described. And as I had mentioned during the previous slide, the parameters including the white blood cell count, C-reactive protein, NT-proBNP, all these have been measured in the baseline characteristics, but they were not taken after the treatment. We do not know what was the response to these parameters after giving 1 gram per kg IVIG. Also, one more critique of the study. Primary coronary artery lesions were seen in only 13, that is 4.7% of the patients. According to Zhang et al., published in Pioneers in Pediatrics, Insights into Coronary Artery Lesions in Kawasaki Disease, in the United States, 2.25 to 3.20% of patients in presentation have coronary artery aneurysms. The data shows that incidence is highest among Asian and Pacific Islanders. Quoting the Japan Health Ministry data, this paper claims that a nationwide survey showed about 9.7% of Kawasaki patients had a primary acute phase coronary artery lesion at presentation. There were only 4.7% patients who had a primary coronary artery lesions. Is the population of this study representative of the population of the nation where the study was conducted out? And can we apply this data on a larger scale when it is not representative of the nation's population itself? Does the paper explain how the study size was arrived at? No effort has been put in this regard. Does the paper explain how quantitative variables were analyzed in the analysis? Yes, the analysis for the quantitative and qualitative variables have been mentioned. Fisher's t-test, application of PET, Fisher's exact test, PET t-test, etc. have been measured. But one suggestion I would like to present here is that between the three groups, before and after the administration of IVIG, tests of significance for response for the secondary outcome, that is comparing between the low risk, medium risk, low risk, moderate risk, low risk, high risk, moderate risk, high risk, whether there was a p-value, significant p-value in their response to the coronary artery lesion size before and after giving the primary treatment, that would have been analyzed. Maybe because the sample size, there are only 13 people to begin with who had a coronary artery lesion. Maybe that's why the authors did not apply. But I feel a Fisher's exact test could have been applied between the two groups. I opine. To discuss regarding the sample size, a similar study was conducted in 2010 at the Diagnosis Procedure Combination Center. The sample size was 1,132. They compared even more parameters like adverse effect profile, length of stay, etc. There was no significant difference in the outcome between 1 gram per kg and 2 gram per kg IVIG as a primary treatment for those weighing 25 kg or higher. That study had concluded. It had a greater study sample size. Does the paper report number of individuals at each stage of study? Yes. Has a flowchart being used? Yes. This is how the results have been presented. 77% of the patients in the low risk group, 72.5% of the patients in the moderate risk group, 74.5% patients in the patients in the high risk group responded to initial treatment as defined as a primary outcome. The Z scores before and after treatment have been presented in this manner. Does the paper give characteristics of study participants in the results? No, there is no mentioning of the sex, the age, or the race distribution. Does the number of participants with missing data for each variable of interest mentioned? Yes. Follow-up time has been summarized. It is a follow-up time of 4 weeks. Other confounders have been mentioned? No. Confidence interval has been mentioned? No. Category boundaries have been mentioned? No. Other analysis of subgroups and interactions done? Unfortunately, no. Does the paper summarize key results with reference to study objectives? Has the paper discussed the limitations of the study regarding bias particularly? Has the paper given a cautious overall interpretation considering all the limitations? Has the external validity been discussed? This is the segment of the paper which discusses the results. As we see, the authors have been affirmative in their tone. They say that the predictive value of the less high risk score was not significantly different than that of the Kobayashi score. They say that we can safely divide the patients into 3 equal groups and make stratified therapies, and later go on to comment about the advantages of stratified therapy in terms to cost and the adverse effect profile. They do not take into light the fact that the new less high risk score has not been peer reviewed. Also, the fact that the Kobayashi score's cutoff has been lifted up, thereby affecting the results. They have recognized one of the limitations. The echocardiographic examination were not performed by the same technician. There is an attempt to recognize one of the bias, that is single center retrospective study, and may be subject to bias. Recruitment bias, Bergsonian bias, etc. have not been recognized, and yes, no effort has been made to address those bias. Conclusion: the authors have put forward the therapeutic response rate and long-term prognosis of patients identified as low risk under the rest high risk score to 1 gram per kg IVIG treatment were satisfactory. Was funding discussed? No. In conclusion, I would like to suggest that this study does not provide enough validation for the clinician to deviate from the standard treatment guidelines regarding the management of Kawasaki disease. Nevertheless, we should appreciate the effort of the author regarding this regard. We need more randomized control trials testing this hypothesis, given the disease burden and the financial implications of the widespread use of a relatively expensive drug, not to mention the adverse effect profile. With this, I'd like to end my presentation. Thank you.
Thank you, Sharon, for that excellent presentation and brilliant analysis. Now, I would like to request Dr. Ramankutty sir to comment on the paper. Over to Ramankutty sir.
I thought of many aspects. First of all, let me say that I had some difficulty in understanding, partly because I'm not familiar with some of the technical aspects. But more than that, I think the language also was a little funny. I mean, I don't blame them because Japanese, they may not be using English on a routine basis, but I thought they could have communicated better. Anyway, that is not the main point. As I understand it, the point that they are trying to make is that you can stratify patients into high risk and low risk, and then modify your treatment. And as the doctor who presented rightly said, it is designed as a retrospective cohort, which means they have gone back to the records, looked at the types of patients. But what I don't understand is if they were deviating from the protocol, I don't know that is justified, because if you're going to do that, you must either do it as a trial or something. Otherwise, on what basis did they decide to do this and went ahead with this? It is not very clear. And secondly, another point that which also was pointed out rightly, they have created some of a score on their own. But usually, when you construct a score or a tool to stratify or to predict prognosis, etc. Now that tool development and its validation itself is a big exercise, and you're supposed to report that separately, whether your tool can be used at all. So that people have a right to know that. They have just said that we have used this tool and this is how it is done. I don't know whether they have published separately. I'm not very sure, but I could not find anything on that. So that is the second point. They just come out with a tool and used it. I don't know how valid that tool is at all. And from the analysis part also, I thought there are some flaws. If you look at the overall result, there are 3 groups they have compared. And if you look at the initial part, the patients in the 3 groups are very different. That's why they are very different. The p-values are very different. So when you compare outcomes in 3 groups which are not standardized for their initial conditions, then you cannot just do a one-way analysis. Opposed to us for the characteristics which are different between the 3 groups, which they have not done. And I think with that kind of resources they have, they could have done it. I don't think it's very difficult to do an analysis of covariance or something like that, or even a regression. But some reason they have not done it. So ultimately what they're saying is there is no difference. So when you report a negative result, again, the sample size is very important. That was also pointed out by the presenter. They have not talked anything about the sample size. When you say it is negative, then you are supposed to say what is the power of your study. So we're not talked about that aspect at all. So when you find a negative result or report a negative result, then you have a responsibility to justify that your study had enough power to say that there is no difference, which they have not done. So these are some of the methodological issues that I would like to point out. Of course, the technical aspects, I think you are more competent than me to discuss that. Thank you.
Thank you so much, sir. Now, I would like to request Dr. Lakshmi Madam to comment on the article as well as the.
So all of us, yes. Am I audible now?
Yes, yes, madam.
Yeah. All of us know that Kawasaki disease is the most common acquired heart disease in children now. And the most effective therapy, only effective therapy available is IVIG, and it is really expensive. So even 1 gram of IVIG, the cost can come up to 2,000. So in a resource limited setting like ours, can we treat our patients based on this study? That is the major issue.
Yes,
Actually, in this study, as sir has already pointed out, they have not used the scoring system which they have used is not a clearly validated one. They have just chosen some parameters, most of which are there in the Kobayashi scoring system with only minor deviations in the values. And based on that, they have scored, divided the patients into low risk, and they have given 1 gram IVIG for this patients. So that scoring system itself is not whether it is is validated or whether we can apply this to our patients, it's not clear. Secondly, and as far as the final outcome is concerned, as Sharon has pointed out, they have examined only the immediate response as well as the coronary involvement at 4 weeks. Immediately after IVIG therapy as well as after 4 weeks is taken as the secondary criteria. So based on this, can we treat our low-risk patients with 1 gram IVIG is the question. If for that, if we have to apply this to our patients, there should be a good randomized controlled trial comparing 2 gram IVIG versus 1 gram IVIG in low-risk patients. And there should be definite evidence for us to treat our patients. That is the problem I see with this study. So for me, I think that based on this study, we cannot treat our patients, even if they are in the risk, with low dose IVIG. That is what I think.
Thank you so much, madam. Now I would like to request Dr. Padmanabhan sir, coordinator of the General Club IAP Thiruvananthapuram, to share his thoughts. Over to Padmanabhan sir.
Okay. I also have many reservations about this. One thing which I don't understand is a retrospective study. And how come they gave 1 gram per kg immunoglobulin? On what basis some patients received this? Because this 2 gram per kg has become standard in the last 4 or 5 years. And therefore, patients received only 1 gram per kg. Retrospective case. And another thing is, regarding immunoglobulin, one thing which has changed in the many times when we get severe Kawasaki with cardiac failure, myocarditis, we are able to give 2 gram per kg in one shot because of the fluid load. We used to give 400 milligram per kg per day over 5 days. And they used to say it has the same effect. Now they are telling no, it has to be 2 gram per kg in 1 day. That is the standard that is given. Now suddenly to say 1 gram is enough is going to be difficult. The only way I can think about is if they have, if we can give steroids along with 1 gram per kg, if it will have the same effect, that will bring down the cost dramatically. That's the only thing I can say. Therefore, definitely, this is export this idea, but I don't think it will make any difference in the because it's too risky. Because coronary aneurysm is something we have to prevent at all cost, from 25% to 5%. Even if a single patient we give 1 gram per kg has an aneurysm, then we are doing the wrong thing. Therefore, as Dr. Lakshmi said, I think this doesn't change the management. Thank you.
Thank you so much, sir. There are a few questions in the chat box, but before we go through that, I would like to request Dr. Purushottam sir to share his thoughts on the article as well as the topic. Over to Dr. Purushottam sir.
First of all, congratulations, Sharon, especially for the last slide of the conclusion. That's a beautiful summarization. And when we consider the relevance of the stratification of the treatment of choice for any disease, let it be Kawasaki or any other one, that is definitely relevant because of many ways. One thing is the financial aspect, which we are bothered when we talk about the Kawasaki and the Gamma. The other one is the safety part of it. when you're using a drug, if it is higher leading on to problems, a safety aspect also. So when we consider Kawasaki, and this research question is a very relevant question, and we need to have an answer. Whether this study gives an answer at the end, no. The study, I think it started from 2009 and ended in December 20. That is one thing. The ethical aspect, definitely, as Ramankutty sir pointed out, even in 2009, the total recommended dose was not less than 2. That was 400 milligram per kg per day, 5 days was the initial at that time. So total was not compromised even at that time. So is it ethical to decide of giving 1 gram, deviate from the recommendation from the 2017 onwards? There's a clear-cut recommendation of this thing. And there is one more important thing. When you're taking 10.5 years of the span, the last 1 year, there was the MISC conditions were there in that group. So you might have noticed that December 2020 and that year, so how many cases of this group which is proposing a condition which is so similar, especially when the investigation we are going through, NT-probe and all, one of the group that was in thousands. So how many cases were there representing every year? The breakup was not there. So how many cases in the 2020 was there included? And how many were coming from the MISC into this group is one point which is not discussed.
Yes, sir.
So the year-wise breakup of the number of cases was definitely relevant, and that is not mentioned. The other thing which I noticed in the low high-risk group, the high-risk group, there were 110 patients, and the classical teaching is less than 12 months. The age-wise is the highest group is always the infancy less than 12 months. Look at the age of that high-risk group. The average age is somewhere around 3. That looks a bit odd. The total number is somewhere 80, 85, and 110 number were there in the high-risk group. And in that group, the age group is somewhere 3. So that again is not the representation of the inadequacy of the sample size, which is not representing the population. That is one thing. At the end, whether it is external validity, whether we can adopt that is all questionable. So I think as all of you concluded, it is yet to get an answer whether we can adopt it. So there is more and more papers and studies are needed before you adopt this thing. It's not yet to be adopted. Thank you.
Thank you so much, sir, for your valuable contribution. Now we had none other than Kerala State IAP President Joe sir with us. Before going to Joe sir, I would like to request Dr. Elizabeth Madam to comment if anything. Dr. Elizabeth Madam, could you please share your thoughts, Madam, with us?
Thank you, Dr. Anju Kanmani, for this wonderful journal club that you have organized. There are a lot of flaws in this paper as pointed out by the experts, but the plus point I must say is the presentations by Dr. Harikrishnan and Dr. Sharon. Wonderful way he has done it. That all of us must appreciate that, and the slope analysis that they have done, very composed way of presentation he has done. But this paper is actually giving a lot of food for thought. There may be other centers which are using 1 gram per kg because 2 gram per kg is not affordable. I have seen other papers also. So I think a working group can look into this. This is a wonderful idea that they have floated. That is stratification and then tailor-made therapy. Wonderful idea. I think the working group can actually look into it, and then there may be other studies. So some meta-analysis can be done based on other studies also, or we can also prospectively do some study which is a multicentric study. And it is important that there should be equal number of representatives in each group. That is very, very, very important. So thank you all the experts, and Dr. Lakshmi has also given a wonderful review of that. Thank you very much.
Thank you, Elizabeth, madam. I think Dr. Harikrishnan sir, there are two questions in the chat box. We can address that actually. The first question is, where can we get the Z score of coronary artery lesion? And the second question is, sir.
Okay, so coronary C scores are easily available on the internet. If you just search coronary C scores itself, parameters, one blog spot will come. So that is based on data from 2011 Journal of American Society of Echocardiography paper 2011 in healthy children. So it is based on that, where they have studied patients from Boston, Quebec in Canada, and I think Washington. So centers in US and Canada. So they have formed a normal parameters, and the C scores can be derived from that. That is what we also use.
So another question is, sir, any other disease with the coronary artery aneurysm other than Kawasaki's disease?
Yeah, so the other diseases with coronary artery aneurysms, all the studies are predominantly in adults. So there we diagnose coronary artery aneurysm based on a segment being 1.5, more than 1.5 times compared to a normal segment. The rest, whether it is, if it's dilated throughout, then it's called a coronary ectasia. So coronary aneurysms, multiple factors have been found out. One is Kawasaki, obviously. The other things are connective tissue disorders like Marfan's, Ehlers-Danlos. Then some genetic influences like matrix metalloproteinases, those have been found out. In adults, the most common cause is coronary atherosclerosis.
Okay, thank you so much, sir.
Coronary aneurysm can actually occur in other infections also. We see a lot of children with coming with febrile coronaries. But how it differs from Kawasaki is that actually in those patients with other form of febrile illness, the coronary dilatation or the C score will be usually less than 2.5, and only there will be involvement of one of the coronaries. If we are getting a C score of more than 2.5, and if more than one coronary like LAD and RCA both are involved, it's more likely to be Kawasaki disease. Recently, we had one child who came in with fever and hypotension, and he had a coronary dilatation, but C score was less than 2.5. And as a child presented with fever and hypotension, it was taken as Miss Bar Kawasaki, and actually the child was started on IV methylpred, and 2 days later the scrub IgM came as positive. So that coronary involvement can occur in other infections also. So child was previously on doxy also, but methylpred was given thinking it to be either a MISC or Kawasaki like presentation. He had some other features of Kawasaki also, like conjunctival congestion, rashes and all. So not only Kawasaki, many infections, many febrile, we see a lot of children getting admitted with febrile illness can have coronary dilatation. But if the C score is more than 2.5 and more than one coronary is involved, it's most likely to be Kawasaki disease.
Thank you so much, madam. I think one more question is there. I think Lakshmi madam can throw light on that actually. It is like this, madam. In a resource-limited country like India, most cases with a low risk score may not need the expensive IBAG and may need only aspirin. Is there a scope for such a study?
That we actually cannot say like that, because we have seen patients in whom who have presented with fever, conjunctival congestion. It was taken like measles, and the fever subsided before 5 days, and they come for follow-up. And we have one child who presented with acute migraine, a history of still like illness.
Sorry, madam. Please continue, madam.
He was having some measles-like illness. He could get the history of illness, but the child presented with acute myocardial infarction. And actually, at presentation, it was like a low risk. No, fever subsided within 5 days. So we cannot say we can treat completely based on that. We cannot say we can treat low dose with aspirin alone, because coronary aneurysm can occur in that group also. Whether we can use 2 gram per kg versus 1 gram per kg, if it is definitely a low risk, is debatable. We don't have definite evidence to say that we can 1 gram per kg is enough, even if it is a low risk. So on all our patients with Kawasaki disease, we give 2 gram per kg IVIG.
See, in the missed patients, with the American Academy of Pediatrics gives more importance to intravenous immunoglobulin. The WHO and I think the IAP guidelines in mild and moderate, we do treat them with steroids. Now, why are we having an allergy to treat with tri-steroids, which would have brought down the cost of Kawasaki treatment? Is it totally ineffective? Is
No,
there any
actually, using
from
steroids.
the beginning? Yeah, from the beginning, in spite of it being vasculitis, we are not giving steroids. We are giving immunoglobulin. What can be the
Actually, there are no studies using prednisone steroids as first line in IVIG. Actually, they give all the studies suggest that IVIG should be given as a first line, and if in non-responders, you can start either IVIG or methylpred. But in MISC, it is different. We had a lot of patients with MISC presenting with even with Kawasaki-like presentation. They responded well to methylpred. And even low dose IVIG, 1 gram per kg, we have given for a lot of patients with MISC presenting like Kawasaki, and many of 90% of them responded to either methylprednisolone or 1 gram per kg of IVIG.
Has such a thing being done in Kawasaki? 1 gram per kg?
No. We have never used 1 gram per kg in
that
Kawasaki.
Would bring down the cost dramatically, is it not?
Yeah.
No, sir, but the MISC situation, even though Kawasaki and MISC looks like basically we don't know whether they are the same. Immune-mediated the predominant involvement in the MISC is the myocardium, and whether we can call it as a vasculitis. Appearance lookalikes matrelo. Coronaries are not preferred. Their myocardium is the site. Where the steroids will work and they are the choice. The role of the IVIG is in a very severe Kawasaki lookalike. Maybe the true Kawasaki, you may be treating with the methylprednisolone only. That will be a grave thing. So we can't take risk. If it is that much lookalike Kawasaki-like, better not to take risk and go for the IVIG. So that
MISC is usually older children. So we cannot give, it's difficult to give 2 gram per kg IVIG for that older child. No, it will be very expensive. So we used to give methylpred as a first line for almost all cases of MISC. Only if there was no response, IVIG was considered. But in Kawasaki, our preference is IVIG 2 gram per kg.
Hari, one doubt, Hari. I was thinking about the SATH score. The study is starting from 2009, and we're relying too much on the SATH score in this study. Even in 2011, but it was not widely used at that time. So how many of these initial years of the study where the SATH score were used also is an important thing.
But sir, it's a retrospective analysis, so they must have calculated these scores at the point of analysis. I suspect that even the score must have been developed later because they would have based it on the Kobayashi score and then did an analysis and found out that this is as effective.
In the study design, there is they are dividing into low, high, and the borderline or the moderate. So there's a lack of clarity in that moderate group. We cannot say moderate unless you are doing both the scoring. That's what I understood from Sharon's presentation.
Yes.
Yes, sir. That is that moderate risk has been added by this group only. But that the group is defined, that is Kobayashi less than 5 and their score higher score more than 2. So that way it is defined, but why add that additional group? Yes, no, I mean that's what I'm saying. They must have made this group later on follow.
Yes.
And to that question on whether aspirin alone can be used, I also don't think that should be done at present. But what we can do is we can identify a low risk group based on some of these parameters and then do a randomized control study only in that group, because high risk or moderate risk is anyway beyond ethical considerations to consider a low dose IVH.
Okay. Thank you for the discussion actually. Now the forum is open for discussion. If any doctors would like to contribute or want to discuss anything on this article, the platform is open.
Hari, not as a part of this paper, what's your experience with the infliximab and the newer modalities for the highest risk and non-responders?
We have used infliximab only in very few patients. Actually, when the after child after we give IVIG, and if the child has persistent symptoms, and on echocardiography, if there is progressive enlargement of the coronary arteries. So we have seen many children when we do echocardiography on one day, and the next day itself, there is marked change in the diameter of the coronary artery. There is rapid progression of coronary involvement. The preferred drug is infliximab over steroids. Especially in small babies, when there is a rapid progression of coronary dilatation, the preferred drug as second line is infliximab. And that market response.
Your question is whether we can go for it based on some of these criteria, like the most important, less than 12 months and all, so that the infliximab can be instituted early rather than waiting for the classical, the definition of beyond 36 hours you wait, one more dose of IVIG or methylprednisolone, not responding, only you go for the infliximab, or can we institute it earlier and skipping that steps and without delaying based on some scoring which you are following?
No, actually infliximab is more toxic drug, no? So it's better not to start, especially in small children. Only if there is progressive coronary dilatation, we will give infliximab, not as a first line. Now, I think some of the centers are giving.
Surjit Singh sir, there was a presentation. He was saying like that in a less than 6 month babies and all, where there is a documentation and all, it's invariably going for a very worse prognosis. Rather than waiting and wasting time, go for this thing, and like that I heard. That's why.
But we are afraid to start infliximab.
He was telling he is having a very good response in that speech and that talk.
Benno sir was about to tell something tell something, sir. Benno sir.
No, actually I was not trying to talk. I was just listening because I cannot make any comments except that I attend the journal club to get an idea of how the experts discuss and interpret the articles.
Okay, thank you, sir. Now, Dr. Jose sir, sir is a teaching faculty at IAP also. Sir is the IAP Kerala president. Sir has joined us actually. I warmly welcome him and request him to share his thoughts on the article as well as the program. Over to Jose sir.
Thank you, Anju, Kanmani, and IAP Trivandrum branch, done a wonderful job in last year. Here also they have started the beautiful journal club, and today the article was very good, presented by the Sharon and Harikrishnan from SATH Trivandrum, and is I think the idea of in the resource setting regarding the low dose IVIG is a new, very good concept, but there is a lot of limitation to accept that in your day-to-day practice. Okay, we need a detailed analysis for that. I think that article was beautifully discussed by Ramankutty sir and Padmanabhan sir and Purushottam sir and with the Lakshmi and all. I think such a very the Trivandrum team doing a wonderful job. Because I am traveling, so they first. Thank you for inviting me to this program. With the Kerala is full support with you to all the academic activity of Trivandrum branch. Thank you.
Thank you, sir, for the cameo appearance and inspiring us all, actually, sir. So we'll come back to the session actually. Now it is almost time. We will have to wind up actually. Sir, with Padmanabhan sir, can I ask a few questions, sir? Actually, queries. Sir, first is Ramankutty Purushottam sir, madam is telling about the scrub positivity with the, the coronary dilatation and that. Sir, we usually come across patients who is having positivity of tests of both scrub, dengue, and multiple tests may be positive. Especially the scrub is a very common this thing, sir. Sir, is it really a scrub, or is it due to some peculiarity of the test that we are using? And should we whether we should take it as a scrub, or whether we should take it as take the diagnosis which is more serious? Sir?
Question is, I always think, how long does an IgM positive scrub last? Because if you read mycoplasma, they will tell you it will last for 1 year. Now in scrub, nobody would have done that study. Therefore, but the thing is that if you have a scrub positivity and you give doxycycline, usually the fever comes down within 1 or 2 days. From that, we infer that it is so. So my idea is, if it is IgM positive and it is responding, and I have found it in very funny situations where you never thought of scrub and suddenly it comes positive, and you give the medicine and it responds to it. And therefore, these two things are good enough. But Dr. Purushottam, somebody can tell me if they have any experience of any study done, whether how long it will be positive. But if you read Nelson, they will definitely tell you IgM in the mycoplasma can be misleading because it can be positive for 1 year. Therefore, that is one thing. But that scrub, I don't know. Therefore, anything, and I expect somebody else to join regarding this question.
But for our child, the PCR was also positive.
Scrub.
So the diagnosis was definitely scrub. But I have seen also previous patients with scrub having coronary dilatations. Previously also I have seen.
It is being reported, no, madam? Okay. Is it described? It is there, no, madam?
I have seen patients with scrub having coronary dilatation. Just dilatation. You cannot say aneurysm, dilatation. Some vasculitis, coronary vasculitis in scrub patients also.
Okay.
Yes, I agree. Lakshmi, there can be coronary dilatation only. The criteria, as she mentioned, is very useful. Other useful thing, as Padmanabhan sir said, we cannot avoid the treatable, eminently treatable entity. So we go usually by clinically. PCR is not affordable, and the antibody confirmation also can't depend clinical. The one thing very useful, simple one is the counts. Because in Kawasaki, MISC and all, invariably you get a very high count ESR and CRP. Rickets is one entity where the investigations are not much disturbed. It's not like the clinical situation you see. Very high grade patient, conjunctival congestion, rash, everything will be there. But the counts will be somewhere in the borderline, around 6,000 to 11,000 in between, not much of neutrophilia, 50-55% only, and not much of change in the platelet count. CSR borderline, somewhere 20-25 and all. But the MISC and the Kawasaki, it will never be like that. The count will be. So very simple bedside test itself can be helpful. So in such a scenario, you are getting a myocardial derangement or the coronary, you can't withhold the doxycycline and go for the IVIG or CRI. That is more important, because in the MISA content on the situation also, what we did in the Trivandrum, Calicut and all, the cocktail type of antibiotics we were using, where the sepsis is definitely a treatable entity. We are using staph cover, ceftriaxone and doxycycline, because few of the cases at least may be among these treatable entities. So that was our policy during that very sick patient. You can't withhold these treatable entities.
Okay. Thank you, sir. That was very useful, sir. Sir, one question to Ramankutty, sir. Sir, is there, sir?
I am here. I had almost decided to go, but then carry on.
Sir, in the study, it is told that, sir, the positive predictive value of less risk is 77%. So, sir, what does that exactly mean? Like the positive predictive value score less ആണെന്നുണ്ടെങ്കിൽ ഈ coronary artery aneurysm വരാനുള്ള സാധ്യത കുറവാണെന്നാണോ? അതോ അവർക്ക് ഈ IVIG കൊടുത്തു കഴിഞ്ഞാൽ ലെസ് ഡോസ് ഓഫ് IVIG കൊടുത്തു കഴിഞ്ഞാൽ അവർ 2 gram കൊടുക്കുന്ന ഹൈ റിസ്കും ആയിട്ട് വലിയ വ്യത്യാസം വരില്ല എന്നുള്ളതാണ് സർ. ആ പോസിറ്റീവ് പ്രഡിക്റ്റീവ് വാല്യൂ എന്നുള്ള ആ ഒരു വാക്ക് അവിടെ ഉപയോഗിച്ചിരിക്കുന്നതിന്റെ ഒരു
positive predictive value, its real meaning is only this, that if you do 100 tests, 100 tests which come out positive, what proportion is truly positive? Understand?
Sir.
So you have 100 tests which are positive, but the true positives are like 80 or 90, and the rest are actually false positives. So it is a kind of a, you need a chart to explain that. So it's like a words of sensitivity, specificity, but there is a catch in this. That is, it depends on the population. So if you do a test in a population which has a high prevalence of this disease, the positive predictive value will naturally increase, whatever be the sensitivity and specificity of the test, because that is common sense. You know, if we have a lot of people with the disease, then you are likely to pick up a lot of people by any test. So naturally the positive predictive value will increase. So I didn't really catch what they meant by this particular statement there. My restriction on this in this particular study is that they have only a very restricted population. So based on that, I don't know whether they can generalize about the positive predictive value. You need a real population study to do that.
Sir, okay, sir. Sir, regarding
the, like, think of the COVID situation. So when COVID is very rare, you do a test, it turns out to be positive, more likely to be false positive.
Sir, I think there's some instability with the sir's connection. So I would like to thank Dr. Sharon for that excellent presentation and analysis, because he has done within 2 or 3 days. We had a trial, but sorry, preliminary stage പക്ഷേ അനാലിസിസും അതുപോലെ തന്നെ പ്രസന്റേഷനും വളരെ ബ്രില്യൻ്റ് ആയിട്ട് തന്നെ ചെയ്തായിരുന്നു. അത് താങ്ക് യു ഷാരോൺ ഡോക്ടർ, ആൻഡ് താങ്ക്സ് ഫോർ മെന്ററിങ്. ഹരീഷ് സാർ ഇത് എക്സലന്റ് മെന്ററിങ് ആയിരുന്നു. സാറ് അത് ഏറ്റെടുത്തത് ഭയങ്കര നന്നായിട്ട് ചെയ്തു. ആൻഡ് താങ്ക്സ് ലക്ഷ്മി മാഡം ഫോർ മാഡത്തിന് മെസ്സേജ് അയച്ചപ്പോഴത്തേക്കും മാഡം സമ്മതിച്ചായിരുന്നു, ഓക്കെ ലെറ്റ് us do it എന്ന് പറഞ്ഞു. ആൻഡ് താങ്ക്സ് ഫോർ selecting this beautiful, this article itself, because നമ്മൾ ഒത്തിരി കാര്യങ്ങൾ ഇത് കാരണം പഠിക്കുകയുണ്ടായി, and the topic was also relevant. And I would like to thank Dr. Ramankutty sir, and Dr. Padmanabhan sir, Dr. Purushothaman sir, Dr. Benno sir, Dr. Jose sir, and Rugmini madam, and Benno, the president and secretary of IAP Thiruvananthapuram, for giving us this opportunity. And if I have left out anybody, please forgive me. And I think we'll conclude the session right now. And Purushottam sir, once more thanks. And I wish all a very great time ahead. And probably we'll find a good article for the next session. And please join us again in the next session and continue supporting us. Thank you so much. Good night.
Thank you. Thank you.
Okay.